start with family interventions because they put the fun in dysfunction. We want to find some ways to talk to them and help them out. What I did is some altered art, just kind of like multi-texture art media to talk about like how I'd feel personally as I went through each stage of the dementia. So, you know, if I were going through my dementia, I really start thinking about the past again, my first marriage, you know, my kids, you know, Vasilopoulos, that was a big part of my life, and that's my oldest daughter, Athena. She's 7 now. She knows everything. I don't know.
Well, we didn't.
I already knew everything. She's too young to know everything right now. I didn't know everything. You could fool me as a kid. I believed in Santa until I was 10. You know, it's like I got a bike for Christmas, and I'm like, I believe in Santa because my mom would never buy me a bike. So anyway, it would be all about family, and everyone has their own cultures and backgrounds and ways that they deal with things, but that one's very Greek. That's why I put that one there. All right. Let's talk about starting a family support group. If you don't have one, it is a great idea to start one. It is a wonderful service that you could provide to the community, but also you are advertising to potential customers that will come to you. It will give good word-of-mouth recommendations for the services that your company provides. It's pretty cheap. You could also provide the service to family members of clients that you already work with. So if you're in home care, this could be something that you do in additional to your foot visit, your foot clinics. You know, maybe you go to ALFs to do a 1-hour support group once a week, or nursing home, maybe you have people come in, or in ALF, maybe you want to do this kind of service where you work. We'll talk a little bit more about caregiver burden, and I will give you labs and resources for activity ideas and courses that you could kind of teach in 10 minutes for family support groups. Then a little bit on respite and prevention. Families are worried that they're going to get dementia because their loved one has it too, and we may want to talk about some preventative strategies. Chances are they're not going to get it. Dementia is mostly sporadic. It just spontaneously happens. There are only a very few genetic dementias that are passed down, and there's such a small percentage. But familial Alzheimer's is about 10% of Alzheimer's cases. If the parent was diagnosed between the age of 30 and 65, then the children have a 50-50 chance of inheritance, and they could take a genetic test to see if they'll get it. That's a personal choice. Huntington's is genetic, and Creutzfeldt-Jakob disease, it's already a 1 in a million chance of getting it, but there is a familial onset which occurs in 10% of those cases, which is a 1 in a million chance of getting. So it's kind of tough to know if it really is familial or sporadic. All right. What are they going through, the family, kind of developmentally? It's kind of an off-time event on their life, so we see that we have some different types of emotions that the family goes through. We always go through guilt. You know, we all have high expectations for what we expect of ourselves and how to help other people. And even if I was completely mature and said, hey, Mom, you're going to go into a nursing home, you know, just so you know ahead of time. You know, that I'm pretty well adjusted. I know that ahead of time, all right? But I'm still going to feel bad. I'm still going to feel really bad because I was kidding. Like, I said it, but everyone kind of hopes that they could do something. But some people just, like, care for people until they burn themselves out, and then they're just done. That's how a lot of people care, too. That's part of empathy drain. I will give and give and give until I have nothing left to give and I'm done, and then you can go, and then I don't feel bad about it anymore. Most caregivers think like that, skilled or not. Therapists, nurse assistants, family caregivers, we're all like that. You stick with a job you don't like, you punch out, you do your paperwork, you go there until finally you're like, I'm done, and they're like, we'll give you a raise. You're like, no, I'm done. I'm just going to the other place. Or they give you the raise and you stay there for like another month. But like when you're done, right? That's how caregivers kind of think. But except for men. Men aren't like that. Men will delegate, coordinate, start things, kind of like manage it, and men are more apt to take a break. They're more likely to step back, so they'll actually do the caregiving role a little bit longer because they get that respite, and the respite refills the cup. Men and women view caregiving in a very different way. Women invest a lot of emotions. I mean, men do too, but they see it as like sticking out a relationship. It's a different way of thinking. We'll talk a little bit more about spousal caregivers too. But grieving, I go through all of the stages of grieving. Every single time my loved one has a physical or cognitive status change, I go through all of Kubler-Ross's stages. Denial, anger, bargaining, and you as skilled caregivers will have to deal with that. And sometimes people deal with many of them at the same time. Some of them go through all of them. Some of them just do one and go back and forth. All right. As a caregiver, you have a lot of stuff to do, and you have to close the accordion to get it done. And when people close their accordion to be productive, when we end up just going on our regular engine speed, we have to make a lot of assumptions to get things done. So think that you're a computer, right? And sometimes your computer says, do you have Microsoft Outlook? Anyone have Microsoft Outlook? Sometimes it says, Microsoft Outlook isn't running efficiently. Could we compress the files? So that we could. We have to compress files all the time in order to function. And there are some common ways that we do that, and they are called mental models. Mental models are necessary for us to make sense of the world, make quick choices for the cause and effect of what we do, and really help us have an understanding and meaning of what's occurring around us. Research has shown that caregivers think in 4 major mental models. 1, golden rule. I want to treat people the way I would like to be treated. You ever do that at work? Ever do that? Motherwit. I will treat my client like my own family member. You ever give advice that you might probably also give your family to your client? Right. Medical model. There's a name for everything, and someday there will be a cure. Social model. Everyone has the right to be valued and involved in their local community, and I will remove all psychological and physical barriers to keep them from doing that. They're all boxes. They're all files, and they're kind of incomplete thoughts, but they just kind of like help us get things done. But they're not complete, and if we always keep the accordion closed, it could be kind of damaging. For example, you have a compressed file folder called Wild Animals. Can you tell me what's on the cover? Give me some ideas of wild animals. Just shout them out. What? Elephant. Tiger. Bear. Alligator. Lion. Oh my. Okay. And then you open up the folder, you decompress the files, and it says, not all wild animals are big and exotic or ferocious. There are other wild animals, like birds and bunnies, right? But when we have to think fast, we got the file folder that goes, right? Because we got to get stuff done. We have to learn how to do that. Children don't do that. That's why they never get anything done. They always keep it open. They're always thinking of every possibility and what-if scenario because they're busy activating neurons. It's kind of sad because it's hard to be creative if we have to close it. But sometimes you need to. So if someone has a closed box and they're thinking in their mental model, you could either open the box, like define it, and get them to think out of it. Not everybody likes to be treated the way you like to be treated. Some people have different expectations. Or not everybody's very nice to their family. Maybe it's not a good guideline to go by. But some people are stuck in the box, and you have to talk to them while they're in the box. Golden rule. We're having a food lab. Everybody come down to my office. We're going to talk about why we want to sweeten up our client's food who has dementia. And I'll take a russet potato and a red delicious apple, and I chop them into cubes. I peel them and I chop them into cubes, and we have a blindfold taste test. And I have everybody pinch their nose, and they can eat a potato, and they can eat an apple. And I say, with diminished smell, can you tell me which one was the potato? Usually, people can't. And I would say with diminished smell, then that means we would want to flavor enhance the food so that our client could enjoy it better, right? I'm using the golden rule to teach people by putting their shoes, them in other people's shoes. Mother wit. Now, I see that with lay caregivers all the time. When people get sick, I'm going to act motherly. You're going to lay down right here. You got a blanket. I'm going to bring you some soup, and it's all going to be okay, honey. Right? We all just start doing that, and we start to see the lay caregiver go, he's my child. He's like my kid. He's like my adopted kid. And, if you want your kids to listen to you, sometimes you got to, let them win sometimes, but sometimes I let them win. And you are in danger of infantizing the client if you're treating them like a kid and you're being all kind of motherly, because, we cover for our own family members. Do you know what people do with their family? If you have dementia in your family, you'll be in denial for a very long time. People who have smart family members, they take even longer to admit that their loved one has dementia. People have daughters and sons that are doctors, therapists, nurses. They're not admitting it, right? If you want to treat your client like your own family member, then we might be covering for disabilities that people have and making mistakes by making excuses for them. You know what I mean? So I might want to talk to somebody in their box if that's how they're thinking. I might say, because think of the mom. She's like, Billy's a good kid. I just think the teacher has it in for him. And Billy's had 26 suspensions this year. We might see a spouse say, my wife is just fine. But in the afternoon, she accuses him of being an imposter, or when he tries to bathe her in the tub, she's scratching or yelling at him. See? So I might have to work with people when they're in their boxes. I might say, well, the client, I tell her, Meals on Wheels, right? And she goes, I'm not doing Meals on Wheels. I've been cooking for myself for 50 years, and Meals on Wheels is disgusting. And I say, okay, well, fine. Let's go cook in the kitchen. We're going to bake some cookies. And I tell the family, I go, did you ever see my big fat Greek wedding? Yeah. And I go, well, the wife, the mother, she goes, the man, he's the head of the family, right? But the woman, she's the neck. She can turn the head any way she wants, right? I have to make things her idea, and sometimes I have to do a little bit of sabotage so she'll come up with the idea on her own. So I let her burn the cookies. I know you wanted cookies, so that's the sad part. You don't get cookies that way. But I let her burn the cookies, and then I show her the tray of cookies, and she goes, how'd those cookies come out? And I go, not very good. And you make this face. Meals on Wheels, right? Meals on Wheels, because this isn't good food, right? And she goes, well, I didn't sleep very well last night, and you're standing over me, and I don't feel good, and there's so much pressure. And I go, I know. There's a lot going on. And when all of this resolves, maybe you won't need Meals on Wheels. But for now, you're right. There's a lot going on. Meals on Wheels. So I kind of get into her head. And it's the same way that I raise my kids. It's the same way that I raise my kids. My daughter, she's like, Mommy, you like my outfit? I'm like, honey, it's sweatpants and a sweatshirt. It's like 90 degrees outside. But it's from Justice. Fine, if you go outside, why don't you just go play for 10 minutes? And if you still feel that way, You could wear your justice outfit, honey. It's like, fine, I will. And I will. Girl changes into shorts and a t-shirt because it's more stylish. It was a great idea that you had. Sometimes I got to go through the back door to get stuff done, make it other people's ideas. Nobody likes to be told what to do at all ages. All right, so how do you do a family support group? It's going to cost you about $50 every time you do it. You probably take that from your marketing budget. The $50 covers the 1 hour of clinician time and the price of juice and cookies to feed the group. Don't skimp on that. You must have juice and cookies. It's comfort. Don't buy bad cookies, good cookies. Okay? And then, so you sit everybody in a group in a circle, all right, and then you talk about a topic for about 10 minutes. Now, I'll tell you why in a minute. And then they get to talk to each other for about 50 minutes. And I'm just there as a clinician to guide the content in case it gets out of hand. Well, I just think he's manipulative. Don't you hate how they're manipulative? And I go, well, he is in late-stage dementia. He might just be forgetful and have difficulty understanding what's going on. Well, that too. You know, but I got to make sure it doesn't get out of hand. All right, what is burden? It's stress of being a caregiver, could result in depression, just going through grief, it is part of the burden. And we see that caregivers have declines in mental, physical, and social health, especially if they are if they are the primary caregiver for a client who has a chronic and progressive condition like bipolar, cancer, AIDS, dementia, multiple sclerosis, or schizophrenia. And if you train a family member to think like a clinician, if you teach caregivers to think like clinicians, they actually reduce their feelings of burden because they're less likely to internalize the day-to-day interactions that they have with the client. They have a name for it, and if they have a name for it, they're more likely to seek medical help when they feel like they're in over their head. The best kind of training is interpersonal. That's why I have 50 minutes of talking. It's better than didactic training. Caregivers just can't think straight. They can't. They're overwhelmed. If you look at their eyes, they're in a fog. They're not looking at you. They're in their own bubble. And if you want to breach that bubble, they're probably only listening to you for 5 minutes, even though you're talking for 10, okay? So what I usually do is I just say everything twice. So some people don't tune in until after 5 minutes, so then everybody gets to hear it, whatever I talk about. And then they get to gab for 50. There's a positive correlation between caregiver knowledge and patient quality of life. So even though family members of clients who have dementia that have doctorates and are lawyers and are therapists and nurses, the patients are having better quality of life even though we're not admitting that they have dementia. We're just seeing a positive correlation between the health knowledge. All right, what are some ideas of labs and lessons that we could talk about during the family support group? SpongeBob SquareBrain is the first one that you might want to do. We're talking about neuroplasticity. I use the idea of an accordion to explain neuroplasticity to you, but we could use the idea of a sponge to explain neuroplasticity to the family. So you get a car peanut sponge like that, get 2 of them, and we're going to say one of these clients has dementia and one person does not have dementia. Let's pass a sponge around, and we're going to give this sponge dementia. And as I pass the sponge, we're all going to rip off pieces of that sponge to represent brain atrophy. You get a pitcher, like a clear pitcher, fill it with water, maybe put a drop of blue food coloring in it so it's more visually salient. Then say, when presented with a change or a challenge, who has the better capability to perform? The sponge that absorbs the most water. So we take the big sponge, the normal brain and say, all right, well, maybe this person's house caught on fire, and you put the sponge in the water, and then bring it to another picture, squeeze the water, and say, when presented with a change or challenge, this person was able to be resourceful, come up with an emergency plan, get out safely, get help, pour it back in. Take the other sponge. This client has dementia. When presented with a change or challenge, what do we get? We go in the water, we squeeze it out. Not as much water. Maybe he didn't remember his emergency preparedness plan. He tried to put fire out by throwing, water from the sink on the fire, and eventually goes outside, doesn't have an emergency plan, says help. Fire gets actually a lot worse because he didn't get help sooner. But we were able to see an observable deficit. And I like the sponge because you're making cognition tangible. And the family members have this kind of like aha moment saying, oh, the client just kind of has less to work with. Like for cognizance and problem solving and resourcefulness. I can also use Jenga to talk about residual abilities. Sometimes family members say, my dad was just fine until he went to you guys. What did you do to him? They say that, huh? Or he was just fine at home. I don't know why he's having trouble here. Jenga is a wonderful analogy to talk about residual abilities versus the client's baseline. All right. I'll try to tell you the technical way first. When I'm at home, I have a routine. Okay? I do the same thing every day. I'm still having global cerebral atrophy. I'm still declining, but repetition is a substitute for my memory loss. Move me out of my familiar environment. You're taking away my routine and observing me at my pure baseline. Prior level of function is a layering of baseline plus routine. Take away routine, baseline's lower. That's why every time you move them, you're going to see a cognitive status change. So change is a bad thing when it comes to dementia. And you have to try to get them to that familiar environment as soon as possible so we can capitalize on prior level of function. But if we wait too long, then prior level of function will fall, and we only have this baseline. They'd have to go back. If they went back to the old setting, they'd need more help. So Jenga. I take Jenga and I show the family. So when people are living at home, they can live at home with surprisingly low cognition. They have their routine that they do every day. But in the meantime, the brain is having atrophy, and you can take out little pieces of Jenga while you're talking. Now, there's going to be no problem. The structure will still stand as long as I have my routine. I'm going to rely on that to keep my structure intact. But let's say that Dad falls and then he has to go to the hospital. It's just like picking up a whole game of Jenga and moving it to another table. What happens when you do that? It falls down, right? So then we go to this new environment, crash, and then acute care says, I don't really know how he's doing like at home, because seeing him here makes me a little nervous. I'm kind of on the edge. Let's err on the side of caution and send him somewhere else for maybe 24-hour nursing supervision and some skilled rehab. Maybe send him over to a skilled nursing facility. So we move Jenga, and then we look at him in the skilled nursing facility and we say, wow, seeing him in this environment scares me. I don't know how he could have possibly lived home alone. Let's think about it for a little while. Like 100 days. Okay? And during that time, he does have some new learning. He finds his room, he gets into a good routine with maybe the therapy team, he's going to the gym, he's doing exercises, he knows his nurse, he knows his caregiver that's coming in his room, he can find his room in the dining room, right? And then for the last 2 weeks of therapy, we're barely able to justify, because he's actually coming down to the gym, grabbing the weights off the wall, knowing what we're supposed to do. But we just do it because we think that we want to keep those skills up. But we go, you know what, though? We think he's going to stay here, right? And then we move him to the long-term wing. crash. You get a re-referral as a Med B beneficiary 2 weeks later. Somebody who fell, they can't find their run, they're having sundowning, agitated kind of behavior with ADLs. Where did this come from? Right? And then we're trying to medicate it because it's a new thing, right? But it all just crashes down, crashes down. What happened? We moved Jenga. Because all that thing we were seeing on the skilled wing, that was all him developing a routine to compensate for more memory loss that was occurring while he was with you. So change is bad. But if change is inevitable, make it sooner rather than later. So Jenga only has to crash once. We don't want to keep it crashing by moving people around and around and around. So maybe it would have been better to send him to the long-term wing first because it was dual licensed. And just in case he stayed there, we were able to preserve the highest level of baseline we could. Same with assisted living. We don't want to wait for someone to decline while they're living in their home to go move over to assisted living. You want them to go to assisted living sooner rather than later, because if we wait for cognition to crash and then move them to ALF, they're not appropriate for ALF. How many people move into ALF and we find out after a month, whoa, 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 what are they doing here? They're not appropriate. So avoid change. But if change is inevitable, make it sooner rather than later to preserve the highest baseline. And Jenga is really the best way that I could use it to explain to the family. We can also talk about specific diagnoses. If you go to the alz.org website, there are links to talk about all of the dementias that I listed this morning if you want a more comprehensive knowledge. Delusions, that would be a fun class. Talk about delusions. What do you do with a delusion? If they do not have awareness of awareness, then you just go with it. It's like improv. That's what you do. Just don't add facts. Just validate, reassure, and if you can, redirect or distract. Don't worry, I'll say that several times today. Talking to Alzheimer's is a book. The 36-hour day is a book. We could read a book and then talk about the content in our group. You could experience Alzheimer's or talk about community and available resources. What's it feel like to have Alzheimer's? We could put petroleum jelly on non-prescription glasses and wear those, and then put in some earplugs. Put some dried kidney beans in the end of cotton gloves to diminish all of the client's senses, all of the family members' senses, then ask them to make a paper airplane and throw it at a target. By messing with all of their senses, it will actually mess with their working memory as well because they're so focused on all this weird stuff going on. And then we could talk about what it felt like. Yes, ma'am?
Just while we're still on family, going back a couple of slides.
Yeah? Yeah, empathy drain is when you give and give until you just don't feel anymore. Like they just, I just don't care anymore. Most people just care for a loved one until they're tired and they're done, and then they just resource out. And then encumbrance is it's a feeling of super burden, which includes caring for your kids, caring for your parents, having to deal with your own emotional and physical issues that are happening as a caregiver, financial stressors, emotional stressors, grieving for the gradual loss of your loved one, and just the day-to-day emotional toll of like trying to get someone who doesn't want to do things to do things. It burns you out. Yeah. Yes, ma'am. When Helping You is Hurting Me by Carmen something. A lot of people do that, yeah. When Helping You is Hurting Me.
And ultimately, the message of the book is, when helping you is hurting me, it's hurting you.
It is. She said the ultimate message is when helping you is hurting me, it's hurting you. That's the thing, if I take care of myself, I'll be able to care for you longer. There's one more book that's helpful. Talking to Alzheimer's, did I say that one? All right, and then the 36-hour day. And I've got lots and lots of books. Delon Pollard wrote a book. It's called Drowning in an Ocean of Cognitive Deficits. And it's like a behavioral encyclopedia for just basically every issue you could possibly see. It's a little more technical. Alzheimer's and Epidemic was pretty good. Still Alice was kind of unbelievable. But she was really smart, so it makes sense that she had a really rapid cognitive decline. It's a work of fiction. Don't Eat the Elephants is about a spousal caregiver, and it's a purple book, and about her husband going through his dementia. It's pretty good, but it's kind of sad. I don't think people like to read about other people's sad stories while they're dealing with their sad story. They might not be ready for it, but if they are, it's other recommended reading. Other ideas for labs, lessons, and resources includes the Alzheimer's website of the Alzheimer's Association, alz.org, AOA.gov, and the Zarkram website. Now, Zarkram's kind of a big site. It's difficult to navigate, but there's a lot of good nursing resources and caregiver resources. I'm a Googler. Sorry. You have all these websites on your reference list, web references. All right. So you click on the girl to enter. It plays really loud music. Then it's really tough to navigate. But if you go under nursing home, nursing staff, that's some resources for you. And then they have a caregiving page, which you can refer family members to. They even have this kind of cool thing. They have a pre-written letter that you could give the client's neighbors ahead of time to kind of have them watch out for your loved one. Like, my loved one has dementia, and if you see her in your lawn and she looks kind of lost, just bring her back home and give me a call. Or so they have lots of different. That's true. Caring for a patient with a strain on marriage. I see a lot of that strain when I do home care, looking at the spouses and their dynamic. Okay. Another website. We'll do other websites in a moment. Were there other questions before I went on?
Where'd you get that under
Caregivers. Under Caregivers on that website. So you go all the way to the bottom of the page where you see the About Us links, whatever. You get Caregivers, and then the nursing home directory, nurses stuff too.